Welcome back to the deep dive. So you've brought in this fascinating stack of clinical research today.
That's right.
We're looking at something pretty universal, but maybe a bit stressful, local anesthesia. Specifically how it's used, especially for kids, to make things like dental visits, well, better.
Exactly. It's often overlooked, isn't it? We focus on the big procedure, but getting numb comfortably. That's really the first step to a good experience.
So our mission today is kind of digging into these sources, pulling out the science, the safety stuff, the techniques.
Yeah, understanding what makes it work well. And the
Ugh.
AEPD definition is key here. Local anesthesia is the temporary loss of sensation, pain, in just one part of the body.
Right.
It's done topically or by injection, and this is crucial, without changing the patient's level of consciousness, they're fully awake.
Body's quiet, mind's totally there. Okay, so these papers give us the roadmap, yeah? From the chemicals involved to getting the dose just right for kids.
It's all in there. The goal is making that moment of injection as smooth and positive as possible.
Okay, let's unpack this. Where do we start? Maybe the basic science. How does this stuff actually stop pain? It seems kind of amazing.
It really is. It's basically neurobiology meeting chemistry right there at the nerve cell. Local anesthetics, they target the afferent neuron.
Those are the ones sending signals to the brain, right? Like pain messages.
Exactly. Think of them as the cables carrying the pain signal from, say, your tooth back to your central nervous system.
And the LA acts like a cable cutter.
That's a good way to put it. The LA drug itself is what we call a weak base. And in its unionized form, it's fatty, lipid-soluble.
So it can slip through the cell wall easily? The membrane?
Precisely. It crosses that fatty cell membrane into the nerve fiber. But once it's inside, the environment changes it. It becomes ionized again, water-soluble.
Oh, okay.
And that ionized form is the active part. It physically attaches to and blocks the sodium channels, the nanoplus channels.
Right, the sodium channel. That's how nerves fire, isn't it? That influx of sodium.
That's the critical step. That rapid rush of sodium ions is the electrical signal. So if you block the channels...
No rush, no signal. The message never gets sent.
Exactly. Pain signals stop before it reaches the brain.
Yeah.
Simple concept, but pretty elegant chemistry.
Yeah, that mechanism is wild. But okay, take that science. How does it translate when you're dealing with a kid in the chair? The challenge feels different.
Oh, completely different.
Yeah.
For a child, giving local anesthetic isn't just technique. It's fundamentally behavior guidance.
Right.
What's fascinating here is how you have to manage this basic physiological thing by really focusing on communication.
So talking them through it.
Yes, but it's more than that. It's using words they understand, nothing scary. It's distraction techniques. It's using topical numbing gel first, letting it work properly.
Making them comfortable before the needle even appears.
Absolutely. Then it's about a gentle, proper injection technique. The success, the positive experience, it hinges less on the drug itself and, well, much more on how it's delivered.
That makes sense. And that delivery depends on the tools, the armamentarium, as the sources call it. 4 main parts, but let's zoom in on the cartridge. That's where the real action is, chemically speaking.
Definitely. The stuff in the cartridge that dictates pretty much the whole risk-benefit picture. You've got 2 main types of LA drugs. Esters, like benzocaine.
Often just for topicals, right? Gels.
Yeah, mostly topicals now. Because if you have a true allergy to one ester, you're likely allergic to all of them, so less common for injection.
And the other type?
Amides. Those are the workhorses. Lidocaine, mepivacaine, articaine is another common one. True allergy to amides, extremely rare.
Okay. But there's more in there than just the anesthetic drug, the vasoconstrictor.
Yeah.
Epinephrine.
Right, usually epinephrine. And this is super important.
It constricts blood vessels. Why is that so critical at the injection site?
It does 2 really crucial things. First, it keeps the anesthetic concentrated right where you need it, so it lasts longer. Gives the dentist more working time.
Makes sense.
Second, and this is vital, it slows down how quickly the drug gets absorbed into the rest of the body, into the bloodstream.
Ah, so it lowers the risk of it affecting the whole system, toxicity.
Exactly. Especially important in kids who are smaller. It's a major safety feature.
Okay, but then there's this complication, the preservative for the epinephrine, bisulfites.
Yes, sodium or potassium metabisulfite. It stops the epinephrine from breaking down in the cartridge. But some people have a true bisulfite allergy.
So if someone has that allergy, you absolutely cannot use an anesthetic with epinephrine.
Correct. You must use a formulation without a vasoconstrictor.
But wait, didn't we just say the vasoconstrictor is key for safety, slowing absorption? So if you don't use it...
Then the anesthetic gets absorbed much, much faster into the bloodstream. That significantly increases the risk of systemic toxicity, of overdosing.
Wow, so the dentist is stuck choosing between the risk of an allergic reaction and the risk of an overdose.
It's a genuine clinical dilemma. It demands extreme care, precise dosing, very slow injection. It's a high-stakes balancing act.
Definitely sounds like it. Let's touch on the needle quickly, too. The gauge thing always confuses me. The sources say use the smallest gauge number.
Yes, and it's totally counterintuitive, isn't it? Smaller gauge number means a larger diameter needle. Think 25 gauge versus 30 gauge. The 25 is thicker.
Okay, so thicker needle. Why is that better?
Two main reasons. One, it's easier to aspirate. That's pulling back slightly on the plunger to make sure you're not inside a blood vessel before injecting vital step.
Right.
And two, a slightly stiffer, larger diameter needle deflects less as it goes through tissue. So it's potentially more accurate.
Got it. And there's a huge safety rule about not inserting it too deep.
Absolutely critical. Never, ever insert the needle all the way to the hub, that plastic part where it joins the syringe.
Why not?
Because if the needle were to break, which is incredibly rare but possible, and it breaks right at the hub, getting that fragment out is extremely difficult. Leaving some needle visible is a key safety margin.
Okay, that makes perfect sense. Now, on to what you called the aha moment, calculating the dose for kids. This seems non-negotiable.
Totally non-negotiable. Kids are not just small adults. Their lower body weight makes them much more susceptible to overdose if you're not careful. You have to calculate the maximum safe dose based on their weight.
The sources give an example, right? A 20-kilo kid using 4% articaine.
Exactly. Let's walk through it. The maximum recommended dose for articaine is 7 milligrams per kilogram of body weight.
Okay, so 7 times 20 kilograms, that's 140 milligrams total. That's the absolute max that child can safely have.
That's the ceiling. Then you figure out how much is in one cartridge, or carpule. A standard 1.7 milliliter carpule of 4% articaine contains about 68 milligrams of the drug.
Okay.
So you take the child's max dose, 140 milligrams, and divide by the amount of one carpule, 68 milligrams.
140 divided by 68, that's just slightly over 2.
Right. So for that specific 20-kilogram child, the absolute maximum is 2 carpules. That calculation prevents accidental overdose simply by giving too much volume. It's fundamental.
That calculation is just baseline safety. Okay, let's move into the actual techniques. Segment 3, starting with just the basic prep.
Right. There's the mental prep, talking to the patient, explaining calmly. Then physical prep, positioning them correctly, drying the gum tissue.
Right, drying.
Makes the topical anesthetic work better. You apply that topical, usually 2-3 millimeters deep where you plan to inject, and let it sit for a minute or two. Really let it numb the surface.
Okay.
Then the injection itself. Stretch the tissue taut, insert the needle gently, bevel towards the bone, aspirate pullback to check for blood.
Always aspirate.
Always. If it's clear, then inject really slowly, like 1 to 2 minutes per cartridge. Slow injection is way more comfortable.
Okay, that's basic infiltration. But what about bigger procedures, lower teeth, needing that inferior alveolar nerve block, the IANB? What you mentioned, anatomy is different in kids?
Hugely different, and this is critical. The target for that block is the mandibular foramen, the little opening where the nerve enters the jawbone. In kids, that foramen is located lower down and further back compared to where it is in an adult jaw.
Just the angle of injection, the depth,
Yeah.
It all has to change.
Completely. You can't just use your adult landmarks. You have to mentally recalibrate for that pediatric anatomy. It's a common point of failure if not accounted for.
Wow. So experience with adults doesn't directly translate.
Not directly for this block. And that leads to another key point. You have to be careful who you give an IAMB to.
What do you mean?
Avoid it in very young children or patients with cognitive challenges who might not understand or remember instructions not to bite themselves afterwards.
Because the numbness lasts for ages, right? Especially the lip and tongue.
Exactly. The pulpal anesthesia, the tooth numbness might wear off in an hour or two, but the soft tissue numbness can last 3, 4, even 5 hours. That's a long time for someone to accidentally chew their lip or tongue raw.
Yeah, that's a major risk. Okay, speaking of difficult things, palatal anesthesia, numbing the roof of the mouth. The sources call it one of the most traumatic injections.
It really can be. That tissue on the palate is stretched super tight over the bone, almost fused to it. There's very little space.
So injecting fluid there creates a lot of pressure.
Intense pressure, which the body reads as pain. You need it for things like extractions, palate surgery,
Mm.
using nasopalatine or greater palatine nerve blocks. But yeah, comfort here is a huge challenge.
Which brings us to some potentially better options, maybe. Supplemental techniques, like the PDL injection.
Ah, the periodontal ligament injection.
Nice.
Yes, this one's clever. It offers a big advantage for that soft tissue biting problem we just talked about.
How so?
It provides good anesthesia for the tooth itself, the pulp, for maybe 30, 45 minutes, enough for many procedures.
Yeah.
But crucially, it causes very little or much shorter lasting soft tissue numbness.
Oh, interesting. So less risk of lip biting.
Much less risk. It's great for bilateral treatment working on both sides because
Yeah.
you don't have both sides of the lips and tongue numb for hours.
But there's always a but, isn't there? A warning for primary teeth.
There is a significant one. You should avoid PDL injections on primary or baby teeth if the permanent tooth bud is developing right underneath it.
Why?
There have been reports linking PDL injections in that specific situation to enamel hypoplasia, basically, developmental damage on the permanent tooth that's forming below. So definite caution needed there.
Okay. This is where things get really interesting, though. The technology stepping in to help with comfort. Like the wand.
Right, the wand. It's a computer-controlled delivery system. Instead of hand pressure on a syringe, which is variable.
Yeah, sometimes fast, sometimes slow.
Exactly. The wand uses a microprocessor and a foot pedal to deliver the anesthetic at a precisely controlled, very slow, constant flow rate and pressure.
So it overcomes that pressure pain problem, especially on the palate.
That's the idea. It
Mhm.
makes those notoriously uncomfortable injections, like palatal blocks, significantly more comfortable for many patients because the tissue isn't being rapidly expanded.
And what about Vibroject? That sounds different. Uses vibration.
Yeah, this leverages neurobiology directly. It's based on the gate control theory of pain.
Okay, gate control. Remind me.
So the theory is that different types of nerve fibers carry different signals, and they compete for attention, so to speak, on their way to the brain. Vibration signals travel on large, fast myelinated nerves.
Like insulated cables.
Right.
Yeah.
Pain signals travel on smaller, slower, unmyelinated nerves.
Okay.
When both signals arrive at a gate in the spinal cord, the dorsal horn, the faster, stronger vibration signal essentially gets priority. It closes the gate to the pain signal.
So the brain perceives the vibration, but not the pain from the needle.
That's the principle. The patient feels the vibration, which masks the sensation of the injection. Pretty clever application of physiology.
That really is using the body's own wiring. Okay, wrapping up, we have to cover complications. Two big ones. Toxicity and that soft tissue injury.
Anesthetic toxicity or overdose. As we said, much higher risk in young kids. Low body weight, faster absorption if accidentally injected into a vessel, or just too much volume given over time.
And the symptoms start with the nervous system.
Usually, yes. Central nervous system excitation first, dizziness, anxiety, maybe confusion, metallic taste. Then it can progress to depression, drowsiness, seizures, even respiratory arrest in severe cases.
That sounds serious.
It is. There's also a cardiovascular response, often starting with increased heart rate and blood pressure, then potentially dropping dangerously low.
And the management starts with prevention.
Absolutely. Prevention is everything. Calculate that maximum dose and stick to it. Aspirate carefully before injecting. Inject slowly. Those are the keys.
But if those early signs do appear, dizziness, anxiety,
Stop the procedure immediately. Lay the patient down if possible. Administer 100% oxygen. Monitor vital signs closely. If it progresses, it's a medical emergency.
okay. The other complication, maybe more common but less acutely dangerous, is that post-op soft tissue injury. Biting the numb lip or tongue.
Yeah, happens all the time, unfortunately. It's purely because, as we discussed, the soft tissue stays numb for hours longer than the tooth does.
So prevention again.
Mostly. Choosing an anesthetic with an appropriate duration, maybe not the longest acting one if you don't need it. Warning the parents and the child very clearly about not eating or drinking hot things until the feeling returns.
And that cotton roll trick?
The bite on this ghost, or fat lip pillow, placing a cotton roll or gauze in the cheek vestibule as a physical reminder not to chew there. It helps.
But now there's something else too, a reversal agent. Or reverse.
Yes, this is a significant development. Oriverse, the drug name is phentolamine mesylate. It's the first drug actually approved to reverse that lingering soft tissue anesthesia.
So what does this all mean? We can actually shorten that numbness period, cut down the risk window.
Pretty much. Oriverse works as an alpha adrenergic antagonist.
Okay, break that down. Epinephrine, the vasoconstrictor, works on alpha receptors.
Exactly. So phentolamine blocks those receptors, effectively undoing the vasoconstriction caused by the epinephrine.
Ah, so it lets the blood vessels open back up.
Right. Increased blood flow rushes into the area, picks up the residual local anesthetic, and carries it away into the systemic circulation much faster.
Washing it out, basically.
That's a good way to think of it.
Right.
It significantly reduces the duration of that lip and tongue numbness. Huge benefit for preventing those self-inflicted biting injuries, especially in kids. It's a real game changer.
Wow. So this whole deep dive, it really shows that giving local anesthesia isn't just a quick shot. It's this complex mix of chemistry, physiology, math,
Physics of flow rates.
anatomy, especially the pediatric differences, and a huge dose of psychology and communication.
Absolutely. And the sources are really consistent on this point. The clinician's ability to give LA safely, effectively, and crucially atraumatically without causing fear or pain. That's probably the biggest factor in whether a patient develops a lifelong positive attitude towards dental care.
Makes sense. Bad early experiences can last a lifetime.
They really can.
Yeah.
So mastering these techniques, using the technology available, it's not about avoiding LA because you're scared of traumatizing a child. It's about leaning in, learning how to do it so well that it becomes a non-event, just a comfortable step in getting care.
Turning potential anxiety into just routine comfort.
That's the goal.
So for you, our listener, maybe a final thought to chew on, so to speak.
Yeah.
We talked about that specific anatomical difference, the mandibular foramen being lower and more posterior in kids. Knowing how critical precise location and slow delivery are, how does understanding even just that one small anatomical detail change how you think about the complexity, maybe the pressure involved in what seems like a routine part of a dental visit? Something to consider.